ESC Studio. My name is Juhani Knuuti. I'm from Turku, Finland, and we are here to discuss about the EVINCI trial. With me, we have here Danilo Neglia, has been the coordinator of the EVINCI trial, and then Richard Underwood from London, who has been focusing on the educational issues as well as the collab of the EVINCI trial. Now, EVINCI trial was a trial which ended by the end of June this year, and it's funded by European Union FP7 program, and that has been also endorsed by the ESC as well as supported by the working group of nuclear cardiology and cardiac CT, and also involved all the imaging working groups. Now it's time to look about the data. Can you very briefly explain what was the goal of the EVINCI trial?
Yes, this trial was a multi-imaging modality trial, and it was designed to look which was the best pathway possible to get the diagnosis of significant coronary artery disease in patients presenting with intermediate probability of disease. And the design was done in a way that each patient received at least one anatomic non-invasive imaging by CT, combined with at least one stress imaging by different stress modalities. And whether one or both non-invasive imaging modalities would have been positive, the patient will get to coronary angiography and get an invasive study plus fractional flow reserve if needed, just to see if there is a major endpoint. So at present we finished the study and we have 697 patients enrolled, and the major endpoint can be analyzed in this population.
Can you very briefly explain what makes the EVINCI trial a unique trial as compared to other imaging trials in the past?
Yeah. First of all, this is a multimodality trial, which means that in the same trial we will explore different pathways in the same patient to the final diagnosis. And so we will have the opportunity to compare in a fair way different technologies and different protocols. The second point in my mind is that it is a multi-center trial, not a single-center trial, and the data, the imaging data, have been anonymized and sent to different core labs, which will and are analyzing the data unaware of other characteristics of the patient. So I think that is one of the first time in which we will have some objective evidence of which pathway in the single patient will get the real diagnosis of significant coronary artery disease.
This kind of multimodality imaging approach must be very challenging to perform as a multi-center trial. So one of the issues is, of course, to how to make sure that the centers will do all those tests, and then, of course, to how to standardize the data acquisition as well as the analysis. So can you explain a little bit more about these aspects?
Yes. This is again one peculiarity of this study, because in the beginning we ran, first of all, a standardization process. And this process was directed by the core labs. So after standardizing the procedures, we performed the studies in the single centers. You are right. There were many difficulties in making the protocol running in many centers, because it was out of the normal clinical practice. However, we at the end succeeded in having the number that was required.
So Richard, you were leading one of the collabs. So how do you comment about this standardization? I mean, how well this was done in this EVINCI trial?
Well, I think it's a very important part of the study that we've done, that every patient actually had two analyses. One was the local analysis, which gave the report of the clinically indicated study being done. But separately from that, we also sent the images to core labs for offline analysis. And the reason for doing this, of course, is to try to standardize the quality. you probably know that one of the problems of a core lab, of course, is that if you analyze images in the absence of clinical information, you're actually losing something from the usual clinical analysis. So it will be very interesting to compare the core lab analyses, which were done in the absence of clinical information, from the local analyses, which were done with clinical information. We've yet to look at that, but it will provide interesting results.
Okay. Then Danilo, can you mention what we know about the results at this point? The study has recently concluded, and then likely we don't have yet the final results, but can you briefly tell what kind of findings we got?
Yes, I have not, as you say, we have not the final results, and we will have these results possibly within this year. However, we had a preliminary analysis based in particular on the local centers' data. And I must say that the most interesting preliminary data is that over 100 patients that present with an intermediate probability of disease because they are angina, there are other risk factors, over this population that currently could be addressed directly to invasive coronary angiography, the real prevalence of an obstructive coronary disease documenting it invasively is only 26%. So we, in a way, are overestimating the likelihood of disease in these patients by current means. In my mind, this demonstrates the utility of this trial because we need to have a better screening of the patient before going to cath lab. Now, when we use non-invasive anatomofunctional imaging in this population, and if we would have sent to the cath lab only patients in the EVINCI population with positive tests, which means a positive CT and a positive stress test, we would have spared, based on preliminary analysis, at least 67% of unuseful coronary catheterization. On the other hand, on those patients that would have referred to coronary angiography because they have evidence of an obstructive significant disease, meaning that it's causing ischemia, over this, the vast majority would have shown really an obstructive disease at invasive coronary angiography and would have been and have been revascularized. So I think that this will be independently of the pathway that would be the best one, we will see, but this is the core message. If we use anatomofunctional pre-screening, we can address to coronary angiography the patient that probably really deserve to be revascularized.
Okay, one of the goals was also to create an educational package for general physicians, but also cardiologists to learn about how to test the knowledge and educate yourself using non-invasive imaging in coronary disease. Can you, Richard, tell about the package which has been recently now released by the EVINCI team?
Yes, of course. We called it EDUCAD, and it's currently released and available through the ESC and the EVINCI websites. You can imagine that with just short of 700 patients in the study, of those, about 350 had nuclear perfusion imaging, a similar number had stress echo, somewhere between 100 and 150 patients each had PET and MR perfusion imaging. So there's a wealth of images there and a wealth of different clinical cases which could make excellent educational material. So the EDUCAD project provides those cases in a format where the user can first of all see the clinical history and then decide which test they might have done next, get the results of that, decide whether they feel that the test is normal or abnormal, and hence move through a clinical scenario much the same as they would do in real life. And we feel that with validated images and knowing the outcome of the patient, this will make an excellent educational tool for people who either want to learn how to interpret the images or to use multimodality imaging in a clinical setting.
Yeah, that sounds very interesting. How many patients there are already today? If you want to go and visit the website, how many you find?
Well, we start small and build up big. At the moment, there are 6 patients available, but we plan to add a patient every month, or 5 patients every month, and so the teaching material will build up.
Okay. And then finally, before closing this discussion, I would just, can you tell when we are going to have the final results of EVINCI trial?
That's a good question. The timeline is done in a way that within the present year we guess to have all the major analysis performed. So with the end of this year, the data will be analyzed by the consortium, and the principal major endpoint will be, let's say, exploited. However, I guess that we will need at least 2 more years just to go through all this data and to provide data regarding to different sub-studies that can be built around the EVINCI data.
Okay, I think I will thank you and thank for the audience of listening this discussion. Have a nice day.